So welcome, James. Thanks you so much for joining us for the Q&A session today. For anyone that doesn't know, I'm Christie. I'm the Head of Patient Services at the Foundation. So I'd like to welcome James along today, and also we've got quite a few people in the room with us today in Click Meeting, which is great, and we're live on Facebook now as well. Just to remember that Facebook is a public forum, so if you want a bit more privacy, you can join us in the room here on Click Meeting. That's an option for you as well. And just before we start, just to remind you that the Q&As that we do here don't take the place of a consultation with your own clinician, and we aim not to provide medical advice, but to provide general medical information. Hi James, how are you?
Good, thanks. You?
Very well, thank you. We've got quite a lot of questions in today, so I'll just make a start on those. And then if anyone has any questions for us at all, please just pop them in the comments box. And as we're going through the questions, I'll pick up any live ones that we have as well. So first question we have is, we've got a patient who's been diagnosed with PBC for the past 12 years and has taken Urso. Their ALP is slightly above normal, but below 200. They were put on statins for high cholesterol, but these brought on weird itch, so stopped taking them. Also on 20 milligrams pantoprazole, you need to keep me right with these, pantoprazole daily for reflux, which they say they can't do without. And they also mentioned that their ferritin is low at 21. And the general question, that's just a bit of background, the general question is, can people with PBC take statins or PPI, and how may that affect them?
Right. The short answer to that is yes, they can. There are several things. Any medication has side effects as well as benefits, and as always, you have to weigh up the risks and the benefits. People with PBC have to be slightly cautious with some of the medication, and part of that depends on the state of the liver disease. In general, most people with PBC can take medications normally. There are some exceptions, and those are listed in the handbook. And you should always, when you're taking medication, whether it's over-the-counter medications, whether it's medications from the pharmacist, the nurse, or the GP, you should always let the prescriber or the or the seller know that you have PBC, and they can discuss with you whether you are at increased risk of side effects or not. Now, with pantoprazole, it's that class of drug that is known as a PPI, or in this case, PPI stands for proton pump inhibitor. Not like it's not one of these mortgage insurance things. If you're asked about PPI, so medicines like omeprazole, esomeprazole, pantoprazole, those are all PPIs, and they're highly effective drugs in reducing acid secretion by the stomach. On the whole, they're relatively free of side effects, and certainly even for people with very advanced liver disease, we prescribe them without undue concern. Statins are a little bit more complicated because statins can cause some degree of liver damage. But on the other hand, the main reason why statins are prescribed is because of high lipids, high cholesterol, and of course, many people with high fat in the blood also have fat in the liver, and they have abnormal liver tests because of that. So what most people will do with statins is to say, well, firstly, do you need them? What are the benefits? What are the risks? And there's huge benefits from statins for many, many people. And the second question is it safe? And what the general practice is and particularly with people with PBC, is to measure the liver tests before you start the treatment, and then say 1 or 2 or 3 months afterwards, and see if they change. Obviously, if you get side effects during that time, you should let your doctor know, or your nurse prescriber, or whoever. But there is now very good evidence that people with liver disease of any type can usually take statins quite safely. There are some other interactions you have to be careful of, but always when you're asked to take any medication and you're advised to do it, you want to know why, what are the benefits, what are the risks, what are the side effects, what you should look out for. And also medications or medicines have a so-called patient information leaflet, or PIL, and you should always look at that, because that is what the manufacturers are required to give in the way of information. Often they say, don't take in liver disease. That's a blanket statement. So if you have any concerns or worries, talk to the prescriber. But the key thing, I think, is to let any person who's giving you medication, let them know you have liver disease. If they're not certain whether it's safe or not, then you could always ask your nurse specialist or your consultant whether the risks are justified by the benefits. But in general, most medicines are tolerated normally by people with PBC as a generalization, but always it's individual, and always speak to somebody if you're not certain. And as I say, drug reactions are very rare in people with PBC as they are in the normal population. So I hope that helps.
Yeah, no, that's great. It's good, sort of a general rule of thumb as well, which is great. There's just mention in the room here that someone can't see or hear us. I just wanted to check that in the room here on Click Meeting, is other people able to hear and see us okay, and just confirm that it looks all good to me in terms of us being live on Facebook, and we are getting some comments. I just wanted to make sure that that everyone was hearing and seeing us okay as well. So if there's any problems, just let me know. So moving on to the next question, not directly related to PBC, but we've got a general question around hepatitis C. Is having hepatitis C since age 19 a risk factor of cirrhosis? It mentions in the bile ducts.
Hepatitis C untreated is a risk factor for cirrhosis, and cirrhosis can lead to problems including cancer of the liver cells. I'm not aware that it leads to cancer of the bile ducts. I'm not aware of that. That doesn't mean it doesn't happen, but I'm not aware of it. But the key thing is, if you have hepatitis C, there are now treatments available, as I'm sure you know, that cure the condition. And once you're cured, the risks are very, very much less. So if you don't have cirrhosis and you have hepatitis C and you're treated, then the risks are very small. So hepatitis C, yes, untreated will progress to cirrhosis and may even liver cancer, not bile duct cancer as far as I know, but treated is a very different situation, like treated pneumonia or treated chickenpox. You know.
Yeah. The next question, again, not directly related to PBC, but came in from a PBC member. Does being diagnosed with chondrial colonosis in my knee have any relationship to having cylindric acid as a drink for 5 years and then 10 years as a yearly infusion?
Okay, thanks. So this question is, chondrocalcinosis is an inflammation of the joints. And as far as I'm not aware that zoledronic acid, which is one you use for the prevention of osteoporosis, is a risk factor, but I'm not a bone specialist. And again, you'd probably do better to get an expert opinion from your rheumatologist or orthopedic doctor than you would from me. I'm not aware of it, but as I say, seek more informed advice than I can give.
Okay, thank you. Our next question is, I have AIH, overlap PBC. My platelets have always been around the 100 mark, but they've now dropped down to 7 to 8. Is this anything to worry about? And they also note that they have cirrhosis.
Right. There are two issues here that I think we should distinguish. The first is AIH PBC overlap. There's been a lot of discussion whether this is a real condition or whether it's just part of PBC. My own view is that it is part of the spectrum of PBC, and in some cases, steroids may be recommended by your doctor. But again, I think that's a separate debate, and there are some very good articles, I hope informative articles, about overlap syndrome in the bare fact that is maybe helpful to look at if you haven't already seen them. Now, platelets, for those who aren't aware, are those very small cells in the blood that are involved with stopping bleeding. So when, for example, you have a blood test, a needle goes into your vein and a small hole is made. And platelets are those small little cells that clump together and start to form a clot to block that hole, to stop you bleeding, and then the clotting mechanisms come into play. Now, platelets are made in the bone marrow, along with red cells and white cells. Platelets are made by producer cells, which are called megakaryocytes, and they produce these little budding cells, which are put into the circulation, and they circulate in the blood until they become old, and then they get taken up and destroyed in the spleen. Now, if you have a low platelet count, it's either usually because they're not enough are made for any reason, or because they're being used up too quickly. And there are many causes for both underproduction and more rapid use. When you have cirrhosis from any cause, including PBC, your spleen gets enlarged very often. And the spleen acts as a sponge. So a lot of the platelets and white cells and red cells get soaked up into the enlarged spleen. And therefore, in people with cirrhosis with a big spleen, it's called hypersplenism. Will have low white cells, red cells, and or platelets. So the first question when you have somebody with an abnormal blood test is to say, is it a real finding? And again, sometimes it's not. It's because there are abnormalities in the collection and the storage in the machine and so on. The second thing is why? And the third question you obviously want to know is it putting the person at risk? Now, with platelets, if you've got an enlarged spleen from cirrhosis, the most common cause is, I say, the enlarged spleen of cirrhosis. That's the hypersplenism. And it's a marker of cirrhosis. If the platelets are falling significantly, then again, you want to check, because sometimes you get a low platelet count because the platelets clump together. They're meant to be sticky, and during the storage, they form clumps. And so when the machine counts the platelets, it doesn't see the large clumps, it just sees the ones that haven't clumped. So sometimes it's just an abnormality, but which has no significance. But if you've got cirrhosis and hypersplenism, then again, a low platelet count, or if it's is not unusual. If it's falling, you may, or your doctor or nurse should be asking why. Is it just the effect of the liver disease? Are you taking some other medication that could affect the platelets, or is there another cause?
Something else going on, yeah.
So then it's not to go from 100 to 80. Sometimes there's variation, as I say. So a single drop, you may not get too concerned about. You may want to repeat it and see if it's real. And then you need to ask yourself why. Usually when the platelets are 80, there's no problem for the patient, for the person. If they get very low, and I've seen people with platelet counts of 1 or 2, then you are concerned because they can't form clots properly, and that's when you get bruising, and so you may want to give additional treatments to mitigate that. So that's a very long-winded response, and I'm sorry about that, but it is Wednesday afternoon, and it's not raining here. If the platelets have been stable and are slightly reduced, then I would talk to your doctor about it, talk to your nurse. It may just be that it's just a one-off. It may be the signs that things are sort of changing in the liver. And so reassure yourself. If it goes up, but it may just go 100, 180, and then back up to 90, and then 100. But if it's 180, 60, then again, I'd want to know why. I hope
That's
that
great.
helps. Yeah.
Yeah, no, that's good. Thank you. The next question we have is a patient who has AS, ankylosing spondylitis, is that right?
Yep.
As well as been on prednisolone. ALP slightly elevated when she cuts the prednisolone down, but she's worried that might mask her PBC. Doesn't have AIH. Also, if ALP is normal range, does that mean we are stable? So that's probably 2 questions there. So yeah. worried about the prednisolone masking PBC. So I would say that's the first part of that. And then the second part is, if ALP is in normal range, does that mean PBC patients are stable? Right.
So just to go back a step, the ALP, so ankylosing spondylitis is a disease of primarily the spine. It's associated with other changes sometimes, and it can be very painful and requires medication and often physiotherapy and expert advice, because it can cause symptoms and they can be rather unpleasant. The alkaline phosphatase is an enzyme that's produced in the by the bile duct cells, but also by liver cells, by other cells, particularly in the gut, in the uterus, and the bone. So a raised alkaline phosphatase can be coming from one of several sources. For example, if you're pregnant, you have a raised alkaline phosphatase. If you have had a bone fracture, or if you're going through a growth spurt because of adolescence, say, again, you'll have a rise in your alkaline phosphatase, but that will not be your liver alkaline phosphatase, that'll be your bone alkaline phosphatase. Now, as all of you will probably know, the alkaline phosphatase is also produced by the bile duct cells and is a very useful measure of, firstly, the condition whether you have PBC, and secondly, if you have PBC, a fall in alkaline phosphatase on treatment, whether it's with urso or other treatment, is a very good marker of response. And how people are offered treatment depends very much on the fall of alkaline phosphatase. We used to go to 2 or so times normal. Now people are going more and more to aiming to normalization. So alkaline phosphatase in PBC is a very useful marker of the condition and guides treatment. But again, if you have a raised alkaline phosphatase, it's not always due to the PBC, even if you have PBC. Whether you're on steroids have a huge number of benefits, but also side effects. And in general, if you're having prednisolone for specific treatment, then I would certainly continue that if it's indicated. I think it's really important. But that may artificially affect the alkaline phosphatase. So yes, do you need the steroid treatment? And if that does reduce the alkaline phosphatase, I suspect if the alkaline phosphatase is coming, say, from bone, then it may or may not, depending on the cause. So like all these tests, you've got to interpret them for the individual and tailor treatment to the individual. So you'll manage somebody with PBC and ankylosing spondylitis differently, and from somebody without ankylosing spondylitis, so individualizing treatment. So if you need the steroids, if you need the prednisolone, I would take it and think, well, okay, the benefits are outweighing any concerns you might have about knowing what the alkaline phosphatase is doing from the PBC point of view. That would be my approach in general. Again, talk about it with your bone doctor. But if the ankylosing spondylitis is being, or other conditions are being helped by the steroids, then you may feel that that is a price to pay. So the alkaline phosphatase is a useful marker of PBC and its response to treatment, but sometimes you have to jettison that in order to get the benefits from other treatments.
Yeah, oh, that's good, thank you. We've got a general question now about potential harm to the liver, and it's asking, what are your thoughts on artificial nails, hair dye, makeup? Do these harm the liver?
My first, I saw that question. It's a very interesting one because unless you drink the nail varnish or hair dye, which I don't think we'd recommend.
I'm sporting all three here at the moment, so.
or sniffing it. So if you inhale, get it into the body, some of these do contain compounds that could, in theory, affect the liver. The issue is the doses are usually extremely low and are probably of little practical significance. The reason why I hesitate with that is there was one large survey couple of decades ago that compared a number of characteristics of people with PBC, of those aged and sex matched without PBC, and nail varnish came out as a very, very slight risk factor. I don't believe that it is related to the cause of PBC, having said that. But that's the reason why I sort of showed a slight hesitation. But nail varnish, and sorry, I'm showing my fingers, they're dirty, I've been gardening. But I wouldn't have thought that there's any risk if you use them sensibly, don't inhale them, don't drink them, and so on. But there is that interesting snippet that says, that there's a very slight risk. I mean, it is tiny, and I think it's of no significance. And men who have PBC, as far as I know, don't use nail varnish. But
I suppose that is the difference in terms of how many women to men have PBC.
Yeah, I think people were getting PBC was being diagnosed long before nail varnish came in. And so I think there's very little evidence to get concerned about for that. But
good, that's good. Next question: if you're stage 1 with no cirrhosis, is calcium deficiency still an issue?
One always has to bear in mind for anybody vitamin deficiencies, PBC is associated, for example, with celiac disease. There is an increased risk both of people with celiac having PBC and vice versa. So yes, one always ought to consider that. One ought to consider it in people particularly who are not exposed to the sun very much, where they can get vitamin D deficiency, for example, living in parts of the world where there's very little sun, or equally where the people dress themselves up and cover their faces and arms and legs and so on. So it's always something to bear in mind, but in general, those issues apart, vitamin deficiency and somebody has a good, sensible, balanced diet, calcium deficiency wouldn't be a problem, top of my list. That's not the same thing as vitamin D deficiency. And I think there is some evidence that particularly women coming up to the menopause, women who smoke, women with a history of osteoporosis in the family, again, may benefit from extra calcium and vitamin D in the prevention of osteoporosis. So we have this question as to whether multivitamins are of value. My own feeling is that as long as you take them as recommended, it will do no harm. And if you are borderline deficient of any of the vitamins or nutrients that are supplied, then it's worth, they'll help correct it. So in general, if you have a sensible, balanced diet, lots of exercise, exposure to sun, and no bowel problems, calcium deficiency is unlikely to be an issue. But that's as a generalization. But, you know, like all these things, you have to bear all these options in mind, irrespective of whether you have PBC.
Yeah, the next question actually touches on that as well. It mentions vitamin A and D and asks if there's an optimal amount that we should have for vitamin A and D.
There are recommendations. I don't have them offhand. Some vitamins are, and the two things to think about, particularly with vitamin A and vitamin E, of the vitamins, 4, A, D, E, and K require fat in the bowel to help them absorbed. And if, for example, you have fat malabsorption and people with advanced cholestasis who are jaundiced may well malabsorb those fat-soluble vitamins, that's a case where you want to have a bit more. Again, if you're taking some medication, such as Questran, that can interfere with the absorption of some of the vitamins. But in general, if you otherwise don't have these issues, there are formal recommended amounts. And usually, as I say, the multivitamin tablets that you can get from the chemist or from the supermarket or even online contain the recommended amount. There are published levels. I'm afraid I don't have them offhand. And in some cases, you may require more, but your doctor, nurse, or dietitian really ought to be, if you're at risk of vitamin deficiency, again, you ought to seek expert advice. But in general, only those with marked jaundice are at risk.
Great, thank you. Our next question is, a bit of background on it is, they've been diagnosed 15 years and an orzo. Noticed with the last 2 liver enzymes were done that their alk phos is rising, 140, and in June 160. Should they be concerned?
Concerned, but maybe over egging it, but I wouldn't ignore it, no. Again, you know, from the discussion about alkaline phosphatase earlier on, you'd want to know, is it from the liver? Is it from other parts of the body? If it's from the liver, then it may be that the dursa verso needs adjusting. It may mean other treatment is indicated. But again, I would want to know if it's a slow progressive rise when it has been stable and normal. I'd want to know why. It's not necessarily meaning things are going rapidly wrong, very much the contrary. But, you know, what's the point of doing blood tests if you don't take action when they become, when they change? So, and as I say, sometimes they get change, a one-off change is just because, you know, the blood took time to get to the laboratories, it sat on the red cells for too long, there was a lab cock-up or whatever. But a continued rise or fall is something I would take note of. It doesn't mean there's anything serious, but it does mean you need to think why. And
Actually, just picking up on a question that's in the room here, which is relative to that, it says, what might some possible causes of elevated alk phos after 5+ years responding to URSO? So similar, we've had a few alk phos questions today, but that kind of fits into what you're saying there. So if we've got someone who's been fairly steady and then for the last 5 years and then noticing that there's an increase, they don't say what the increase has been from to, but just if there's any possible causes of an elevated alk phos.
I mean, there are many causes, and the first thing I'd think about is, the question is it from the liver, or is it from, have you had a fracture, have you had a fall, vitamin D deficient, are you pregnant, have you got bowel problems, etc. If it's from the liver, so normally that's why most hospitals will measure the gamma GT, another enzyme that goes up and down in parallel with the liver alkaline phosphatase. It could be due to one of many factors. It could be, for example, due to the fact that your dose of URSO needs to be revised. If you put on weight, you may not be taking enough. It could be that your liver needs, the PBC needs additional treatment. And another question is, has there been any change in medication? Because, and it's not just prescribed medicines, it's over-the-counter medication. Are you taking any extra vitamins that can cause a raised alk phos? Natural remedies, turmeric, all those things can damage the liver as well. Just because they're so natural doesn't mean they're safe. So are you taking any other medicines? And I also include alcohol in that, although whether you call that a medicine or a necessity, I think depends on, or a luxury, depends on your viewpoint. Is there something else going on in the liver, for example? Are you getting fatty liver? And so on. Do you have gallstones? And so on. So again, there are many, many causes. And if it's a change, then you need to know why. Because as I say again, there's no point in repeating. So you either repeat blood tests to reassure yourself things are stable, but if they're not stable, then you want to say why. Often it's a trivial, non-serious cause, but you never know till you try and identify it. And so I personally always take these things seriously, looking for, but not necessarily being concerned, because most of the causes are not serious, but sometimes there are, and they need treatment to keep you well.
Great. I'm just going to jump to the last question that's in our list that we sent to you, is just because you touched on it there. So one of the questions that we did get in was, can I take turmeric supplement with having PBC? Just you mentioned turmeric there, so I just thought it might be an option to bring that in now.
Yeah, I'm always slightly careful about natural remedies and so on, because when you take a drug like, as we talked about, pantoprazole, it is very carefully monitored. It's prepared under licensed conditions. The regulators, the MHRA will look, and they will often inspect to make sure that things are done properly. With a lot of natural remedies, and I'm not knocking them because some of them are effective, there's far less control, and because they're natural, they often contain more than one chemical. They often, again, many of the ones from, I don't think it applies to turmeric particularly, contain different chemicals. If you, some drugs, for example, some preparations, if you take them from the stem or the leaf, you get different preparations, different times of year. Again, the contents, because plants are like that, they'll change. So that may be a strength, that may be a weakness. Because they're natural doesn't mean they're safe. I once organized some lectures, and for the Royal College of Physicians, and I got somebody to talk about complementary medicine. And she said, if people tell you complementary medicines don't work, just tell them to take a few Senecot leaves tonight and come back tomorrow and tell me they don't have an effect. And many drugs are derived from plants that people knew, for example, that foxgloves used to treat heart failure very effectively. And then it was William Withering who identified that it was digoxin. We don't use that much now. And vincristine, which is a very effective agent used in some cancer therapy, comes from plants, and so on. So quinine from the bark of the cinchona tree, aspirin likewise from plants. So plants certainly contain a lot of chemicals which have beneficial therapeutic effects. So I'm not knocking them. I think with turmeric, the evidence it does any good is very limited. My own feeling is if you want to take them, absolutely, but take them in the stated doses. More is not necessarily better, any more than 5 tubs of ice cream is not more rewarding than 1 tub or 1 bottle of whiskey, and so on. More is not necessarily better, but be careful. And if you do notice any changes for the worse, stop taking them. If your liver tests become abnormal, that could be a cause. But in general, when natural remedies work, they get taken up by the pharmaceutical industry and marketed. But as I say, I think there's relatively little evidence that these drugs like turmeric, curcumin, and so on do work or have a beneficial effect. But most people, I think, naturally feel, well, conventional medicine's not doing a huge amount for me. Let's try alternatives. And if they do work, if you do notice a huge improvement symptomatically or biochemically or whatever, let us know, because we can learn from that experience and share the information. But don't assume they're safe. Don't exceed the stated dose. And they are relatively safe, like all other interventions. They are not. No medicine is free of side effects, natural or pharmaceutical.
No, thank you. That's good. Our next question is around swelling legs. So we've got a patient who says their legs swell during the day and night, but by morning after sleeping, the legs are back to normal. However, as soon as they're back up and moving again, they're back swollen again. Could this be related to PBC? It
could be, but it could be related to many other factors. It could be related to heart conditions. It could be related to medication. It could be related to your liver. It could be related to many other causes. So if it's a bit of swelling when you're standing in the hot weather, it's usually nothing to get worried about. But if it's significant, go and see your doctor, find out why, and have an appropriate treatment. So mild swelling in the hot weather, again, I think that's fairly common, and that usually doesn't mean anything's going on. Yes, swollen ankles in the context of liver disease, there are many causes, and it depends on the state of the liver, but there are non-liver causes. So don't ignore it. Go to your GP, do the blood tests. He'll take or she'll take a history, maybe examine you, send you for further tests if appropriate. But significant swelling of the ankles, don't ignore. If you think it's related to your liver, first talk to your nurse or hospital doctor, because they'll know if it's simply attributable to the liver. And if it's not, then make sure that somebody tries to find it. Again, I'm always coming back to this. If there's something changing, ask yourself why. Mm-hmm. Is it something to get concerned about? Is it something I should ignore?
No, that's really good advice. Thank you. Our next question is around a patient saying diagnosed in 2020 and has had significant foot pain since then. Joint pain causing difficulty walking. Seen multiple podiatrists with no improvement. Is there a link to PBC?
Yes, is a short answer. People with PBC do get bone pain. They do get joint pain, both in the big joints like the knee, hip, elbow, but also in the small joints of the hand. There are a number of different mechanisms. There are many different causes. Treatment tends to be relatively symptomatic, i.e. Pain relief, but of course that has its problems. But if the podiatrist hasn't been able to help, go to your GP and again think of why. But joint pain, bone pain in people with PBC, we don't know the cause very often if it's related to PBC. But as we've said so many times in the foundation, just because you've got PBC doesn't mean everything is due to it. You can still win the
that, isn't it? Yeah.
You can still win the lottery and have PBC. They don't go together. And there's a tendency to say, oh, it's all just the PBC. Sometimes it is, sometimes it isn't.
I'm just going to pick up on one of the questions. We've got quite a few questions coming in live as well, but I'm just going to pick up on one just because you touched on it there, and that is what painkillers are okay to take if you have PBC. You just mentioned there about joint pain and painkillers, so I thought that was a good time just to sneak that one in.
This is a bugger of a question because again, you have to treat pain. Pain doesn't ennoble the soul. Pain doesn't make you a better person to live with, quite the contrary usually. Sometimes you, quite frankly, if it's not too severe, you have to live with it. The second point I'd make is that there are other treatments available as well as medicines. Heat treatment, cold treatment, compresses, lotions, and so on. There are all sorts of additional physical treatments that people find effective. So don't think only of hitting the paracetamol or other painkillers. And physiotherapists are often extremely skilled at finding the physical treatment that works for you. So just bear that in mind. When you have pain, the two common drugs that we use are either paracetamol or a group called non-steroidal anti-inflammatories, or NSAIDs. Paracetamol is one of the standard drugs. One has to be careful because taking too much can and does cause liver damage and liver failure. People with advanced liver disease, including PBC, are slightly more sensitive to the effect of paracetamol. So if you do take paracetamol by mouth, take no more than 6 or 8 a day without talking to your doctor, because it can build up and it can damage your liver. The other group of drugs, the first line drugs, are called the NSAIDs, or non-steroidals, which aspirin was the initial drug that we use, but now Brufen, naproxen, ibuprofen, and so on are the ones that you can get over the counter. You have with PBC to be careful because you are more sensitive. They can cause irritation of the stomach lining, gastritis, and ulcers, and it can also cause liver damage. Non-steroidals can cause liver damage in people without PBC, but if you have PBC, you're more susceptible, and they can cause acute liver damage and long-term liver damage. So you have to bear in mind the risks as well as the benefits.
Mhm.
If you're going to take painkillers, take them sooner rather than later. It's easier to prevent it getting worse than to treat something that's worse. Sometimes topical treatment, ibuprofen gel or whatever, can help. And that, certainly if your liver is safer, because less is absorbed. Otherwise, you're onto the much stronger drugs like fentanyl, morphine and the hydrocodone, those sort of classes of drugs, which are very effective in pain relief, but they have side effects and issues, particularly such as drug dependency. And we've seen in the States where fentanyl dependency has become a huge problem, many, many deaths caused by it. So pain, if you can't live with it, again, it depends how severe, where it is, and all the rest of it. Think of physical treatments. Will supports help? Will splints help? Will physiotherapy skills help? Will topical gel help? If not, paracetamol within limitations. But if you're going to take Brufen or ibuprofen or whatever, do talk about it with your doctor first, because there are side effects. But again, going back to my old mantra, you've got to balance your risks and your side effects
I think
with your benefits.
I think if you're experiencing severe chronic pain as well, a referral from your GP to the pain specialist clinic can be really beneficial, because not only do you speak to the pharmacist there, you get access to physiotherapy. So, and that can be really helpful as well if it's something, the question doesn't specify if it's just taking it for occasional pain or if it's ongoing chronic pain. So I just thought it'd be worth mentioning as that, just to ask for a referral if it's something that's been ongoing and it's severe.
Absolutely right. Absolutely, I should have mentioned that. You're absolutely right. The other thing which and the other thing about pain relief, there are sometimes people will give a drug called amitriptyline to supplement the pain relief. Now, I mention that particularly because amitriptyline was used a lot, much less so now, for the treatment of depression. Now, yes, people with chronic pain can and do get depressed. That's to be expected, really. But low dose amitriptyline, 25 milligrams a day, that sort of dose, once or twice a day, is very effective in helping pain relief. So if your doctor suggests amitriptyline in those sort of doses, don't assume he or she thinks you're depressed. As I say, you may be depressed because of the pain, and the treatment for that is treat the pain and sometimes antidepressants. But if you're going to treat for depression, you probably wouldn't use amitriptyline. And I've had a lot of patients who don't take the amitriptyline because they say, I'm not depressed. And of course,
think it's for that, yeah.
They're right, they're not depressed, but they're not being prescribed it for that. But pain clinics are getting a lot better. The only downside is it's a bit like going to Eton. You have to put your name down at birth. There's often too long a waiting list.
Yeah, I think it's worth, if it is something that's been going on for a while, think about asking your GP for a referral. I know some patients have found that really beneficial.
Yeah, that's absolutely right. And do it sooner rather than later. You can always cancel if you can get on top of your pain.
Great. So I'm just moving on to what is our last question in our list that we had sent in prior to the call. So we've got a patient who's saying, both my mother and sister have PBC. I had blood tests about 6 years ago. I have positive AMA and positive ANA, constantly always slightly raised GGT and ALT. 50 years old. I also have Sjogren's and lupus. The question is, it has been left up in the air with an official diagnosis or whether I should be on Urso, but they do take Plaquenil. Does that make sense?
Yes.
Plaquenil.
Plaquenil, yeah, for the lupus, yeah.
So I think there's maybe not actually been an official diagnosis around the PBC part, and whether or not they should start on Urso. So just to see what you thought about that.
I would go and see a hepatologist, a liver specialist. Let them have your history, let them talk it through with you. I know what I would do, I think, but as you said at the beginning, Mo, we must be careful not to give medical advice. I think you can guess the way I'm thinking, but I would go and see a hepatologist because it's important to get a diagnosis if it can be done properly. So I'd ask your doctor or your rheumatologist, whoever's looking after the lupus, to speak to a hepatologist. If you have a problem or your GP doesn't know the local one, the foundation will be able to point you in the right direction.
Yeah. Brilliant, thank you. That's all the questions we've had in ahead of the session. So I'm just going to we've covered the questions that are in the room here in Click Meeting. So I'm just going to go over to Facebook, and we've had 2 questions in relation to Q10. So I'm just going to start with the first one because the next one follows on. So question is about coenzyme Q10. I have PBC with compensated cirrhosis and recently started taking coenzyme Q10, and it's been really helping with the fatigue. Can someone with PBC take this long term?
Yes, the role of coenzyme Q10 has been a subject of much debate. David Jones actually did a formal trial with a small number of patients, and their trial didn't show any significant benefit. Yet, on the other hand, people with, a number of, like that respondent, has found them of benefit. So coenzyme Q is pretty safe as far as these things go, again in recommended doses. So talk to your hepatologist or liver nurse specialist. But in general, I think if it's helping you, I would guess the risks outweigh any benefit, because the fatigue in PBC can be so debilitating, as you as listeners will know.
Yeah, a couple of weeks ago, actually, we talked about fatigue quite length a couple of weeks ago with Dave, and he'd mentioned the Q10 at 100 milligrams, because some of the patients were asking about Q10 and what dose to take. The next question that we have is just around it. Is asking more in general, explain how PBC fatigue is different from other forms of fatigue, and that they'd been advised that coenzyme Q10 is very unlikely to help with PBC fatigue, and wonder why this might be. But I suppose that's the thing. It may help some patients. It may not have an effect on others.
Yes, I mean, the simple answer is we don't know why people with PBC get fatigue, and equally, it's become clear to me over the years that what people mean by fatigue often differs, and how it affects people again differs. It differs not only between people, but within. So over the years, it may change. And of course, there are many reasons why people might get fatigue over and above having PBC. That said, there's no doubt in my mind, and in I think every other liver specialist, that it's a very real entity and can be very, very severe and really affect people's quality of life. What causes it, we don't know. We know that we believe it's in the brain. That's not to say it's in the mind, it's in the brain. And one of the factors that, again, comes into it, as far as I'm concerned, in the mechanism, is that after liver transplant, the fatigue. So if you've got advanced liver disease, like any other serious advanced disease, you'll get fatigue and brain fog as well. With PBC, you get it also in the early stages. But if you transplant people, again, we've done these studies very carefully, it doesn't really improve. And so whatever causes the fatigue in PBC, it's outside the liver, and replacing the liver doesn't seem to make a difference. The foundation is involved in setting up a trial of a drug which we think might well work in in PBC for fatigue. And the problem is that the regulators, the people who decide whether a drug should come to market and also whether it's available on the NHS, want to quite rightly have clear evidence that it works. So what we have been doing, and Mo's been instrumental in this, is setting up a measure of fatigue and all the different aspects, including brain fog, pain, and so on, and distress, to try and quantify it, to put a number to it. And it's rather like putting a number to happiness. It's very difficult to do that. But if we're going to have a drug, A, it's got to work, but B, it's got to be shown to work. So by trying to quantify, saying you took the drug and your level, say, was 8, and you then take the drug and your level goes down to 2, that could be a very important test. So
absolutely,
doctors have been slow to get onto the importance of this. And it is a real issue. But why you have fatigue in PBC, I don't really know, nor does anybody else, sadly. If I did know, I wouldn't be telling you on this today. I'd be writing it up and getting the glory, as with other people. But we don't know. Yes, we know it's real. We don't know why. How Q10 works anyway is unknown. We know that, for example, deficiencies of some enzyme and other chemicals and elements can cause symptoms, but that doesn't mean giving more than you need will correct that. So we don't really know, and I would be happy with empirical, if it works. So if fatigue's a major problem, you're not getting any help or support from your doctors or nurses, and you want to try Coenzyme Q, try it. If it works, great. If it doesn't work after a month or so, stop spending your money on it. It's unlikely if you take it at the right dose, it'll do any harm. Give it a month. And if it works for you, then you may want to continue taking it, but always let your doctors or nurses know what you're doing. But how it works, I don't think anybody really knows, not with any certainty. We don't know, as I say, until you know why people get fatigue any more than we know why people get itching. But we know they do, and we know it can be nasty.
I know we're just slightly over time here, but we've got 2 questions in Facebook from newly diagnosed patients that I'd like to ask if you've got time for that. James, is that okay? So we've got one who's saying, new with PBC and has been taking Urso for just over a week. Is it normal to experience strong stomach pains below the belly button? They're taking 100 milligrams a day in total.
It's not normal, but it's not uncommon. But if it's getting symptomatic, and don't stop it, but talk to your nurse or doctor who prescribed it and ask them what you should do. There are a number of options that available to you, but if it's persisting, don't suffer in silence. There are, as I say, there are a number of approaches you can take to that. It's not uncommon, and it can be dealt with.
Great. And another one from a newly diagnosed patient is, how frequent is ascites in PBC patients? They were just diagnosed but have a distended abdomen.
Again, many reasons for distended abdomen, and it depends if it's gas or fluid or, medical students are taught it's all the F's, flatus, which is wind, fluid, fat, fetus. So a distended abdomen is not uncommon, but again, you want to make sure that there's nothing going on. If you've recently been diagnosed, you may well have had an ultrasound and that will have picked up if there's fluid there, for example, and if there's fluid there, then obviously that needs to be taken very seriously. If it's a bit of distension, well, that may just be the PBC. But again, if your doctor's examined your tummy, if you had an ultrasound, then it's probable that any serious cause will be picked up. But distended abdomens are not uncommon, both with and without PBC indeed. But if in doubt, raise it with your doctor, with your nurse, and they can examine you and either reassure you, investigate, or treat depending on what the problem is. As I say, don't put everything down to PBC, but
be careful, yeah.
It may well be due to it all the same.
Yeah, no, that's great. Thank you so much. As I say, it was just because it was two patients who were newly diagnosed, I wanted to try and sneak them in. Just a reminder to people who are joining us as well, we do take questions in advance of the session. You can send them into linda@pbcfoundation.org.uk, and we try and get them in by midday on Wednesday before the session on the Thursday, and we'll make sure that your questions added in for that. So thank you so much for everyone that's joined us today. James, special thanks to you. I always like our sessions where, you know, I've had PBC for many years, and I learn something new every time we do these Q&As. So, and I think that's the same for a lot of the patients that join us. So it is really appreciated.
Well, no, if I can return that, I've been working with PBC people for slightly longer than that time, and I continue to learn too. So by hearing stories, by hearing what people find, it's also really useful feedback, because, you know, just as the foundation can pass the word, so can the doctors, and that's always helpful. We always learn.
Yeah,
But I'd love to see the day when the foundation closes because the condition's cured, but I think we're both in business for a little while longer.
No, that's brilliant. So I'm just going to end our session on Facebook Live here. Thanks again to everyone who's joined us. If your question wasn't picked up today, I'll pop through the comments, but I will take a note of it for our next session, which is next week. So thank you again, James. It was lovely to see you.
Thanks, Mo.
And I'll see you again soon. Okay, thank you. Take care. Bye-bye.
Bye.